I am an extramural NIH funded researcher based in New York City, and I work mainly with people who inject drugs who migrate from Puerto Rico to New York City. We're monolingual Spanish speakers, migrants, very vulnerable population in the city. And I also come here as an experienced community-based organizer who co-founded 11 years ago and continues to run, free of charge, in kind, a syringe exchange program called El Punto en la Montaña. So from those perspectives of service provision, from a very radical health community perspective, and science, I come to you to present my take on the state of affairs in Puerto Rican, drug users and their health and their vulnerabilities. So let me see. That's that, no disclosures. Those two individuals are participants of our syringe exchange program. We serve Sidra, Calle, Agua Buenas, Comerío, and Caguas, El Punto en la Montaña. They're in Sidra. That's a shooting gallery that's typically used to inject drugs, and they've never, ever been tested for HIV or Hep C, if not in prisons, when they were doing time in Guayama or Guayama Mil or some other prisons. Prisons are main focus points for getting tested for these individuals, at least individuals that we see in rural Puerto Rico. This number that we see here is crucial, 28,000. That is the latest global estimate comes from the latest global estimate done by Louisa Degenhardt and her team in Australia that produced this estimate of the population of people who are injecting drugs in the world, and they estimate that in Puerto Rico, pre-Maria, there were 28,000 people who injected drugs. That figure is crucial for this entire presentation because it really changes the way we look at the epidemiology of HIV and hepatitis C, because we have a denominator now. We have a scientific guess of how big the population actually is. I've been doing this work of studying their vulnerabilities of injection drug users in Puerto Rico and their counterparts in the Eastern Seaboard, in New York specifically. And this is the first time that I come across a denominator for Puerto Rico. It's awesome. So I'm hoping that we can have a debate about this and what I think this looks like, and if there are any concerns about it in the audience, I am really, really looking forward to talking about it. It's a conversation. So while we have this amount of chunk of people who are injecting drugs, a considerably sizable part of our population injecting drugs, we also don't have governmental support for the 5 syringe exchange programs that we have running in this country, one of which I co-founded and support, El Punto en la Montaña. 11 years of ongoing harm reduction work, only partially. We've distributed over 1 million syringes. We have recuperated used ones, approximately half of those from the communities, potentially infected needles. But we're doing this work for 11 years with a budget of $90,000 a year. Minimal. Why? Because we don't have enough support, right? That is the predicament of other syringe exchange programs. I would also dare to say that it is also the predicament of ANSCA. ANSCA is funded by the government, but ANSCA needs more funding. 6 clinics are not nearly enough in the island, are not nearly enough to attend. If we're looking at this denominator again, ANSCA, you do the math. By their own reports, they see approximately 5,500 people who inject drugs are receiving methadone in this. So what is the percentage of the unmet need? We need to do better. And I think that that's the message that everybody here has been saying, and it is the conversation that this revamped Puerto Rico hopefully is going to continue having, right? We need to fund syringe exchange. We need to fund methadone. These are evidence-based interventions that nobody questions. They work. But yet, we also know that Puerto Rico is consistently funding faith-based programming that we know do not work, are not efficient at having HIV prevention, hepatitis C prevention, overdose prevention. They don't work, and yet we fund those. Based also on the 28,000 denominator, PWID denominator, you have, before Maria, assuming a 3.4 million population in the island, you have an injection drug use rate of 823, easily. The highest injection drug use in Latin America, followed only by Brazil, very below in the 450s. So thanks to the work that Sandra, Miranda, and Yadira and the team of NHPS and Vigilancia SIDA do, we have a picture of what the impact is, right? On the island, geographically, we have those 5 municipalities that are carrying the burden of cumulative HIV/AIDS diagnosis, about 47,000 as of 2014. This is the data. Currently today, about 19,000 people are living with HIV/AIDS. And of those, Vigilancia SIDA has documented, not an estimate, has documented about roughly 6,000 of those 19,000 are PWID linked, which puts us at a 31% of all of those that today we know have HIV, 31% are PWID linked. We are very far from eliminating PWID related HIV in this beautiful island. And granted, this is not to say that people who inject drugs are the main risk population. Men who have sex with men are the most vulnerable. We know that. And yet, we also know that PWID are the ones who are the most likely to die. And we got to talk about, right, mortality. So, going back to this, Luisa Degenhardt's estimate of 28,000 PWID for Puerto Rico, that means basically that if we combined Vigilancia SIDA's 6,000 diagnoses of people who inject drugs who are receiving HIV medications, who we know are HIV positive, and we divide that by 28,000, then we could arguably say 1 in 5 people who inject drugs are HIV infected. Again, very, very, very high numbers. I'm going to shortly, in a few slides afterwards, I'm going to show you what the numbers are for New York City. And you will see, incidence is almost 0. Prevalence barely reaches 10%. We're very far from reaching that point, and we know why. But we have an opportunity through this conference and our allegiances to change that and to make it better and to save lives, right? That's why we're here. So cumulative HIV incidence says, Vigilancia SIDA reports, was among people who inject drugs between 2008 and 2014, almost 20%. Again, these are very high numbers, and this other number of 42% has been shown already in other presentations here. That's the latest cumulative PWID-linked HIV cases that we've seen since 1981 through February 28, 2019. So again, just very, very high amounts, large numbers for PWID. PWID population, like most of the United States is talking about MSM, and Puerto Rico is still talking about PWID, right? And again, it's really not a mystery. It's because we're not funding syringe exchange, and we're not funding nearly enough methadone and buprenorphine programs throughout the city. Carlos Rodriguez, started documenting prisons in Puerto Rico as a risk environment that is structured into producing HIV and producing Hep C, because the prisons are flooded with heroin. There is probably more heroin inside prisons than there outside. There is a very high prevalence of injection drug use inside prisons, Puerto Rico. It is no mystery why everyone has Hep C. Shooting galleries. Diana Hernandez was the most recent one to document the existence of shooting galleries that are risk environments. that continue to inform the sustained prevalence and incidence of HIV among people who inject drugs. And again, you know, I'm mentioning Diana and Carlos now, but this is stuff that was Fafi Robles, Hector Colon, and Johnny Andía and Sherry Darren, of course, have been documented since times immemorial, and we're yet to do something about this. I think this is what we need to look at. What we haven't been doing, and this is going to be part of hopefully the conversation that we have in the Q&A. Mortality, again, Hector Colon, since times immemorial. More recently, Dr. Melissa Marsan, where she highlights that you know, among people who inject drugs living with HIV, they have a 53% higher risk of dying when compared to MSM or high-risk heterosexuals living with HIV/AIDS. These numbers are, it's to me, baffling. and it's baffling because we can do something about this. We can. We know how to do it. All we need is the political will. Hepatitis C, Juan Carlos Reyes Pulliza, many years ago, documented that it could be up to 90% among San Juan people who inject drugs. In rural Puerto Rico, 80% we know of our participants, our constituents, we know that service-wise, we know that research-wise, are hepatitis C positive. And yes, many of them are getting it in prisons, but they're also getting it outside prison. We don't have any surveillance. Cynthia Perez, Carmen Albizu have called for surveillance and treatment. Local scientists have been doing this work and have been calling for this. We are yet to have it. We don't know how big the problem of hepatitis C is on the island. We just have very, very uneducated estimates around it. And we don't have treatment. If you are indigent in Puerto Rico and you're an injection drug user, you will have to leave the island to get hepatitis C treatment. Those are the people that I, as a researcher with my researcher hat, use and see over there in New York. We can do better. Enter Maria, of course. We have to talk about Maria. We're all talking about Maria because Maria traumatized us, and none of us were ready for this. El Punto en la Montaña, we saw people injecting with that's the La Plata River right there in Comerío. That's Comerío 2 weeks after Maria, when our team managed to get their lives together and then go and resume activities, syringe exchange activities. Our participants were injecting drugs with that water. Skin infections surged. And this is not really about the Department of Health not doing X or Y. This is about us just being able to learn from what didn't happen so that it doesn't happen again. Global warming, more hurricanes are coming. Are we going to be ready next time? Overdoses. You know, AIDS United and MAC AIDS funded we escorted people living with HIV from Comerío and different municipalities into Caguas and San Juan to get medications, thanks to AIDS United and MAC AIDS Fund. We did that, and we also flooded those municipalities with solar-powered appliances and with water sterilization equipment, very expensive stuff. We were able to purchase that so that we could avoid having that. Injection drug users using agua con bache. Right? I'm from Barranquitas, by the way. I grew up right next to this river. Overdoses surged, and they're still surging today. Where am I going with this? We're not doing surveillance of overdose. Fentanyl is present in both cocaine and heroin supplies. How do we know that? Well, El Punto en la Montaña, just like many other syringe exchange programs here in Puerto Rico, we purchased the fentanyl testing strips. And we test empty drug bags, cocaine bags and heroin bags, across the 5 municipalities that we serve. They all come up positive. It's always positive. And our participants know it. And crazy enough, some of them are even looking forward to the fentanyl because it's a guaranteed, better high. It's a culture of craziness, right? That things get crazy very quickly when you're that dispossessed and that indigent. In March 2019, Puerto Rico legalized over-the-counter naloxone. It's not doing nearly enough. None of my staff at the syringe exchange program has been able to even identify a pharmacy that carries it in this 5 minutes. It's not doing anything to save lives. You know, and here are the slides of the US, and I'm going to run through them quickly because, you know, for the sake of time, you know, we can't talk about the United States without talking about Héctor Colón. We cannot talk about the United States without talking about Fafi Roble, que descanse en paz. And we can't talk about the United States and Puerto Rico in the United States without talking about Sherry Darren. They've been documenting since forever that there are structural determinants of illness and vulnerability in Puerto Rico that are non-existent in New York, and that makes a difference between life and death. This is not a new documentation. This has been documented. Cynthia Perez with the hepatitis C here locally, and these individuals, the most comprehensive comparison of 2 different geographies with 2 different structures, the Department of Health wise. Because I got acquainted with that work, I decided to do something about syringe exchange, creating a syringe exchange program, and becoming a scientist myself. So there are about 100,000 people who inject drugs in New York, and that estimate is old. It was done by geography by Barbara Tempalski, a friend of mine. There are 23 syringe exchange programs in New York City. New York City alone, not New York State. There are more in New York State. No, I'm wrong. It's New York State. They're all government funded, unlike in Puerto Rico. Just flooded. The city is flooded with HIV and hepatitis C prevalence and treatment. They treat using Medicaid, PWID. People who inject drugs are eligible for treatment in New York City. What an idea, right? And there are studies right now being conducted on sustained viral SVR. What does the R stand for? Response, thank you. So there are studies being conducted right now by Brian Etlin and Pedro Mateo Galavet from Spain, and etc., that are trying to assess, are we reaching SVR among PWID? Some studies suggest that it will be possible. So why are we not offering that here? Why do they have to migrate? So that they can meet my face over there, right? No, they could stay here with their family members, with their loved ones. When they go there, and my presentation is not about migration, but we have to talk about migration. When they go there, the likelihood of homelessness is probably, 60, 70%. There are 69 methadone clinics in New York City alone. That was the number that was in New York City alone. About 30,000 patients. So New York City has like this very, very aggressive pro-harm reduction, lots of opioid agonist therapy vectors, or places where people who inject drugs can actually access care. Unsurprisingly, 10% prevalence only among people who inject drugs in New York City, and incidence is almost at 0. Don Desjarlais, one of the most important researchers we have in New York City, and I think the US, it's actually calling for the end of the epidemic in New York City among people who inject drugs because incidence is so low. However, there is a cautionary tale here, and that cautionary tale comes through the fact that New York City's PWID population is increasingly Puerto Rican. And it's increasingly Puerto Rican because of the migration that I've already been discussing here with you, right? And those Puerto Ricans that are going over there become homeless very quickly because some of the programs that they are offered over there don't really work. They're immediately disenrolled and end up on the streets, where researchers like me end up recruiting them to understand why they are where they are. Those individuals continue to be super, super HIV risky, super, super hepatitis C risky, and access to CEP and OAT is not enough. It's not enough because these individuals are coming to New York City with an entire risky subjectivity. It's how they learned to do things. And then they go to New York City And they're not just gonna erase their history of risky injectors, risky injection drug use, and sharing paraphernalia, which is built into the way they know how to inject drugs. They're not going to erase that like that. We're not computers, we're human beings. It takes time to re-socialize into a new harm reduction environment. What I'm saying is just to help you understand, NHPS, just like Yadira does here in San Juan, I was involved in NHPS 2009 and 2012 with injection drug users, and over there, you have that population, 28% of all the Puerto Ricans, or more than 50% of the sample, were migrants in 2009. In 2012, that went up to 34%. I don't have the data for 2015, but I'm pretty sure it's gonna be around there, right? Everybody knows, in every piece of study of PWID in New York City establishes that at least half is Latino. And unfortunately, however, they're not being specific enough to say which Latinos. And that's the battle that I am, having over there, because we need to be specific. It's Puerto Ricans. It's not Mexicans. It's not Dominicans. It's us. It's our people that are living here because this is a service desert. And they go there to find another set of vulnerabilities and barriers that keep them vulnerable to HIV, Hep C, and overdoses. I don't have this information here in my slides, and I only have 4 minutes left on my presentation, but in 2017, and I don't have that, I didn't include that here, but in 2017, the Department of Health conducted a study of who's more likely to die of an overdose, and in the Bronx, Puerto Ricans are constituted 67, migrant Puerto Ricans, 67% of all overdose deaths among Latinos were Puerto Ricans. These are individuals who didn't have to leave their beautiful Puerto Rico in the first place. We can do better. We can keep them here, treat them here, and get them to reintegrate into work and school and etc. here. Because what they're facing, most of them in Philadelphia, New York City, in Chicago, where they're going, it's a whole lot of uncertainty, and they are alone. As I said, migration doesn't fix it. My NIH-funded study went into sort of like inspect why doesn't exposure to SEP and OAT fixes it. I'm not gonna discuss it here for the sake of time, but we can actually, and that's my most recent publication on exposing what are the rationales of sustained risk in spite of, ample access to services in New York City. Why do you continue to be so risky, right? And that paper explains it, and we can talk about it later. So these are my final 2 slides. If science has already shown that SEP and OAT dramatically decrease HIV incidence and controls Hep C incidence, if science has already shown that free of charge Naloxone access saves lives, like literally saves lives, then why are we not funding SEP in Puerto Rico? Why are we only partially funding OAT? And why are we not providing PUID with Naloxone free of charge access with these things that will keep them alive? Systematically engaging in any of this could bring the HIV epidemic and the overdose epidemic to a halt, just like New York City did. And it would also, of course, decrease migration. They don't have to leave. Their migration, in most cases, is not a choice. It's structurally forced because they don't have the resources they need to stay healthy here. So those are the bottom lines and the conclusions. So we don't need more science to stop HIV and reduce Hep C among people who inject drugs. We just need a government that funds evidence-based programming. And by evidence-based programming, we mean stuff that we know work. SEP and OAT. Mi Salud should consider covering Hep C treatment. So many guys, so many folks are here with HIV and they don't have access to the cure. The cure is available. They don't have access to the cure because they're too indigent. And because we have restrictions, an abstinence restriction that eliminates them from the pool of possibilities. I don't think that's public health. I don't think you do too, either. In New York and other states in the United States have already found that you can go around this Medicaid loophole if a drug like Harvoni or Sovaldi is approved by the FDA Medicaid has to cover it. That is the legal argument that across the US, territories have been using, states have been using effectively to treat people with Hep C using Medicaid, indigent people. So it's possible here, there's a precedent. We don't have to reinvent the wheel. And we need, people are dying, right? Overdoses and HIV related illnesses. Well, let's do overdose surveillance to see where we need to start, flooding the area with naloxone. Without overdose surveillance, we can't save lives. HIV care should be PUT-friendly. A lot of people who inject drugs are scared of doctors because they feel that they're going to be judged. You're just a junkie. What are you doing here? Stop using drugs and come back. Of course they're not going to go to the doctor. I wouldn't go to the doctor in that predicament. I think we need to talk about these things in the most honest fashion, and I hope we do in the Q&A. And thank you I want to thank specifically Syringe Access Fund, AIDS United, MacAIDS, Red Hot, Direct Relief, and Gilead for funding El Punto en la Montaña, NIDA for funding me in New York, and of course people living with HIV/AIDS and drug users. I'm only striving to be a fair medium for your unheard voices. Puerto Rico Concra, thank you for being our fiscal conduit for El Punto en la Montaña, and the team from El Punto. Thank you.